To talk to you a little bit about now is the aspect of something that's called sciatica, which is what most people have heard of before. The medical terminology is lumbar radiculopathy. Yeah, I know it's a mouthful. We'll break that down in a minute. And if it's coming into the arms, which can be a similar type pain, it's called cervical radiculopathy. We're going to talk about that, but more importantly, we're going to talk about the treatment options thereof. In one of the other talks that I gave to you was a context of a disc bulge and what that exactly means. This we're going to talk about more of the clinical signs that's associated with it and the various different types of abilities to be able to treat it from an epidural standpoint. The reason why I'm giving this talk in the first place is I've had a number of patients that have said to me, I've had a shot before, it didn't work for me, there's no reason for you to consider repeating this again in the future. And quite honestly, when I probe them further, what I asked them is, okay, so what type of quote-unquote shot did you have? Or was it an epidural? They frequently will say yes. I'm like, well, what type was it? And they're like, what do you mean? The doctor, number one, never told me what other type it was. Number two, I don't know where it happened to have been located. And number three, I wasn't even quite sure why I was getting that shot in the first place. So those are going to be some things that we're going to give you a little bit further insight about. And hopefully when you walk out of my office, you'll know, number one, why you're getting it if you're going to get it. Number two, why we're doing that particular technique and what we might do in the future different if we had to. And then additionally, where it's located and why it's located in that area, in that region. So first and foremost, let's talk about the elements of lumbar radiculopathy or sciatica. So when most people hear that, what they hear is, you know what, I have this pain that is present, that's in my back, and it goes down my leg. Sometimes it'll go all the way to the knee, sometimes it'll go all the way to the foot. And what we want to kind of have an understanding of is, why is that the case? There's a number of different reasons. The most prominent one is the one that I mentioned earlier of you having a disc bulge. But typically, it's because that nerve is inflamed somehow or it's compressed. And what an epidural does is it gives medication in that area, in that site, in an attempt to try to relieve that compression or that irritation. So most people will say, well, how does it do it? What's present within the aspect of an epidural? What's present in the aspect of the epidurals that I give is a mixture of steroid and local anesthetic. If you want to know specifically, it's a mixture of marcaine as well as dexamethasone. And the reason why I choose the medications that I do is because they've never had any problems with infection, and they've never had any issues with giving a problem if that medication got in and around the vessels that could cause other issues. It's a clear type of steroid, and the steroids that we use are not manufactured from any place outside of a regular stock company. So to dispel those issues, okay? So how does the actual medication work? The local anesthetic is really something that just kind of calms the nerve. It's a temporary process. It's not something that we're really expecting to utilize for it to give you some long-lasting relief. But more so is the steroid. The steroid has to get into the area in and around those tissues that have some degree of inflammation, and in essence it decreases that inflammation. It calms it down, in other words, for all intents and purposes. So the premise would be, well, how do we get that medication there? And how we get that medication to that area is we basically utilize a needle. What I'm going to show you is, with the context of a Q-tip, how we're able to get that medication into certain spots and different anatomical orientations, and why that can be somewhat impactful. So when we take a look at the elements of the spine, as you very well know, the present model that I'm showing to you is oriented. So this would be down towards the feet, this would be up towards the head, the back is to you. This current Q-tip is placed in between the areas of two vertebral bodies. It's in the space that we would enter in order to get to that right space. This type of epidural is called an interlaminar or translaminar epidural. In essence, it allows for that needle, if my Q-tip was the needle, to enter right in the middle. Why would we consider doing it this way? There's a couple different reasons. Number one, historically, the epidurals have been done this way because there's a certain sensation that we can feel as pain physicians or anesthesiologists to be able to get into that space. It's actually called the ligament inflavum. It feels kind of like the bubble wrap that you have, which you wrap some objects in when you ship it. You can feel that sensation as we get to the right space. As we get to the right space, which is the epidural space, it's like a vacuum, like you'd have either in your machine or in space. And we, at that point, stop and we give the medication there. It's not into the nerve, it's not into the spinal cord, but it's into the space. And the reason why is that medication then it works its way to where it needs to get to. It doesn't necessarily have to be placed exactly in that area, and plus to do that is a bit traumatic anyway. So this interlaminar way is the way that's been done back since the 1800s when epidurals were first started. So this, if you're a woman and you've had a labor epidural, or you've had a C-section, or you've had a spinal tap for any reason, is a common way that your doctors are going to do or perform in order to get into that space and spot. For a pain patient, we will sometimes do it this way, particularly if we're in other elements other than the lumbar spine, but it's not always our most common way to approach it. It can be helpful for elements that have components of ligamentum flavum hypertrophy, which I've probably talked to you about a little bit in another previous talk, or occasionally when you have pain that's on both sides and we need to give you some medication to be able to distribute it appropriately. What I'm going to talk to you secondly about is the element of another type of epidural that's called a transforaminal approach. And what that entails is actually entering through the foramina. And I know I've spoken to you once before in the context of being able to use the foramina and what comes out of that foramina space, and that's the nerve roots, as you know. So if I was to turn this towards you and we show you a different area, what you can see is that there's a nerve root that's present here. It exits from that hole that's called the foramina, which is the exit point from where the spinal cord produces its nerve root, and it comes out in this area, in this region. What we sometimes will use as pain physicians is to use that same exit route as an entry route for us. So we'll take that needle, designed as my Q-tip here, and it basically enters in this space and this spot, not at the nerve, but into this area here, into the epidural space. The way we're able to determine this, much like the other epidural and any epidural that we're utilizing, is we're looking at it under direct fluoroscopic imaging. So we can be able to see that needle as it starts to all the way to when it finishes. So we can be able to look at the element of safety to make sure you're not going to have an issue or a problem. The needle that we use is actually smaller than the size of my Q-tip here, and basically we're placing medication in and around the area of the disc, which you can see in much closer proximity than what we had with the interlaminar, and we can see it's placed closer to the area of the nerve root. What we use this for frequently is for those that have disc bulges that are quote-unquote paracentral, bulges that are coming off to the side. And so we're looking to be able to give medication to be able to prevent that bulge from continuing to causing a problem as it currently is doing. So that's our second type. Sometimes, and one of the reasons why I presented these two in conjunction, is we'll use them in combination. We'll use a transforaminal and an interlaminar to be able to give you better relief. Will we do that right off the bat? No. I would think the way to go about it is under a common sense approach, is what we utilize here, is if you only have to be stuck once, who wouldn't take that option? No one wants to be stuck multiple different times. So that's the reason why we'll choose one versus the other, but then accordingly, we'll make a plan from there. Which leads me to another point that I want to kind of touch base on. A number of patients will come and they'll talk to me and they'll say, Dr. Landrum, my other doctor told me that I needed to get 3 epidurals in order to feel better. Should I schedule 3 epidurals? And I'll be frank with you right off the bat, no. I wouldn't want to get scheduled for 3 epidurals if I didn't have to, and I would not have my patients do the same either. The reason why that 3 epidural rule was put in place is that a number of years or so ago, there were physicians who worked in conjunction with insurances to figure out how to be compensated appropriately. And what they basically came up with was this context of doing 3 epidurals consistently, and frequently the same type of epidural, to be able to try and treat a patient's pain. To me, from a clinical standpoint, that doesn't really make a lot of sense. The way I think about it is if we do one thing initially and it doesn't work, then what we need to do is consider doing a different approach in order to get a better response. And so that's what we talk about. And that's one of the reasons why when I have a patient come to me and say to me, you know, I've had a number of injections and they haven't worked. That's why it's important for me to understand, what did your other docs do? How did they do it? What was their progression? What was their frame of thought? And how did they conceptualize this, and how they brought you in to be part of the decision-making process? So that's the context of us looking at the components of an interlaminar or translaminar epidural, and in the context of looking at a transforaminal epidural. The third one that we're going to talk about is the element of a caudal epidural. And so a caudal epidural entails the utilization of the caudal space, which is present. And most people are like, what space are you talking about? I've never even heard of that before. So a caudal epidural is an epidural that uses something that's called a sacral hiatus. And so when you look in very closely, and I'm going to move the Q-tip here for just a second here, you can see that there is an opening. There's a hole that's present here. It's a sacral hiatus. This area is right down at the very base of your bottom. And what we utilize is we use a fluoroscopic assessment live x-ray, if you would, to be able to identify that space. And we give you a local anesthetic like we do for all of these prior to the needle being introduced, right at that area in that site. And then what we do is we take that needle and we place that needle right into that spot. Depending upon the context of the actual injection, sometimes we'll give you just medication through the needle itself. Occasionally what we'll do is we'll take and we'll run a small thin tube from this area all the way up to your area of interest and give you medicine not just at this spot, but at multiple different spots. Many people have not had an injection like that. It's really helpful for patients that have spinal stenosis because we are actually able to some minimal extent, decrease some of the scar tissue that you have there and the narrowing that's present. Not always, but frequently we can. And on top of that, we can give you medicine at multiple different spots so that you don't have to be stuck in a whole host of different areas and regions. So that's the context of a caudal epidural and how we go about performing something like that. The other areas that I'm looking to talk to you and discuss about are the areas when we go outside of the lumbar spine, or where we go to when we're talking about other than the low back. And so some of the areas that we look at are the components of the neck as well as the mid-back, or specifically the cervical and the thoracic region. And so when we do those type of injections, we utilize a similar approach as what I described in the very first one of these, which is that interlaminar or translaminar approach. So if I was to bring this model over here for better view, when we're talking about doing a cervical approach, in essence, we're going to have you laying face down, much like we do for most of these, and we're basically going to take a needle and we're going to place it just low in the neck, and we're going to let that medication spread up to where your issue and your problem happens to lie. By the same token, if we knew you had a problem that's present within the mid-back or the thoracic region, we're going to place a needle at one spot. We're going to give you medication pretty close to that spot. But here we can be able to move that needle closer to the area of interest because this is a fairly large region and we want to try to get that medication as close as we possibly can. So that's the context of looking at an epidural, what it can do, how it safely is utilized, and what are the differences between one variation versus another and how that might be effective for you.